PVR, which was, you know, the pigment in the vitreous, rolled edges of the break, non-fixed folds in the retina. You know, they were the changes of grade B PVR, but then it had grade C PVR, but it was only C1, C2, C3, and C4, which was just the quadrants, how many quadrants were involved. And then it had grade D PVR, which was when you would look with a 20 diopter lens at the retina, and everything would be closed over the disc. You couldn't see the disc from the, so it became apparent over time that that really wasn't an adequate classification to really explain the pathology of PVR and what you're doing surgically. So in order to address anterior PVR, they moved to the later Retina Society classification. Basically, this was a committee of eminent people that were the Retina Society had asked to do this classification. Included Robert Mockemer and Tom Auberg and quite a number of people. The 91 classification had anterior PVR and posterior PVR. So they said posterior PVR was, if you read it, it says posterior to the equator, and anterior PVR is anterior to the equator. It didn't say whether it was at the equator. Is it posterior to the equator or anterior to the equator? And they further broke it down into types of contraction, of focal contraction, which is basically a star fold, diffuse contraction, which is a larger area of contraction, which generally indicates you've got multiple star folds that are confluent, that are coming together, and it just contracts a larger area of the retina. And so the type of contraction, the focal or diffuse, could be either anterior or posterior. Then they had what they called a circumferential contraction, which was when you get a contraction of the vitreous base, where if you get a fibrosis and contraction of the vitreous base at the posterior hyaloid, you'll end up with this knife-like pulling forward of the vitreous at the vitreous base. At the posterior edge of the vitreous base will be pulled toward the center of the vitreous cavity, because you've got some fibrosis affecting the posterior hyaloid. And it'll contract, and you'll just see the vitreous base, the posterior edge of the vitreous base is pulled in toward the center. So that was circumferential contraction. And then they had what we used to call, Steve Charles had originally named this anterior loop traction. And this is basically, this is now just called basically anterior contraction, where where you get contraction of the vitreous at the vitreous base, pulling the retina posterior to it forward. So basically you can end up with the retina sort of behind the pars plana at the posterior edge of the vitreous base, contracted up toward the pars plana. And in the worst case, it can be pulled up to the pars placata, or even in the far worst case, it'll be attached to the posterior iris, pulling the iris posteriorly, where you've got complete organization, fibrosis of the vitreous base, basically pulling the posterior retina forward and then it's basically, you've got this loop of redundant retina anterior retina that's beneath this area that's pulled forward. So then the silicone study, which was from about 1986, I think, to 1991, the silicone study further defined it by clock hour involved. They used basically the same group of classification as the 1991 Retina Society classification. And a lot of the 91 Retina Society classification came from the silicone study, but they used clock hours involved. So basically, if you had grade C PVR and it involved two clock hours, that was C2. So it'd be, if it's grade C PVR, which is fixed folds, you have CP, and if it was anterior, it'd be CA, or if it was both anterior and posterior, it'd be CAP. It'd be both anterior and posterior, and then the number of clock hour involved. So it could be a CP12, could be CP12 CA6. I mean, it's however many quadrants, posteriorly and anteriorly. So the silicone study further classified it by clock hours involved. And I actually think the silicone study classification is the best, because it really does give a very tight classification of exactly what type of PVR, where you've got anterior retinal displacement, the retina pull forward, whether you've got, the type, and then the quadrants involved, and what's anterior, posterior. So I think you need to understand the classification system, and I think both the Retina Society classification and then ultimately the silicone study classification are the two best to use. Oh, before it was called PVR, originally it was called massive vitreous retraction.
Yeah, MVR.
It was MVR, and then Mockemer then in the 70s gave it a new name called massive periretinal proliferation, MPP. So it was MVR, and that was when there was this sense that there was just some sort of magical vitreous contraction. Nobody knew exactly why it contracted, but there was this massive contraction of the vitreous, and so it's called massive vitreous retraction. And then when Mockemer recognized that it was cellular proliferation that caused the contraction of the vitreous, then he called it massive periretinal proliferation, MPP. And then the 1983 Retina Society classification is the first time it was renamed as PVR, proliferative vitreoretinopathy. So that was the way the name
So let's move forward a little bit in terms of medications, surgical approach, medications, any adjunctive. What's Dr. Abrams? I know you usually you start with some oral steroids before your surgery for a couple of days, and we were just talking about this that we feel like the eye afterwards looks a lot more quiet for the degree of surgery that we did. In terms of the other adjunctive medications for PVR, anything that's been found to be useful? For oral steroids, there's never really been any study that's shown that eyes ultimately do any better with oral steroids, but there was this interesting study a few years ago by out of Germany, where they randomized patients with they were patients that had primary retinal detachment that had
signs that were indicative of high risk for PVR. And these were eyes with a lot of flare, or eyes with multiple large breaks, eyes with maybe a little hypotony with them, breakdown of the blood-ocular barrier, things like that. So they randomized these patients to either preoperative oral steroids versus no steroids. And they had a fairly large study, and it was a blind study. They found that in eyes that received the steroids, they had a significantly reduced incidence of macular pucker in these eyes, which, I mean, it's a proliferative process. They did not find a statistically significant reduction in the development of PVR or the final outcome, but they did find a definite, or at least a statistically significant reduction in epiretinal membranes. So, I always took that as sort of a marker of proliferation and PVR, even though they weren't able to prove that. And I it's probably just my bias, but I really thought the eyes looked much better in the early post-op period. They had less fibrin, less inflammation. If you gave them, I'd start them about 48 hours ahead, because it's been shown that if you give steroids before the insult, they're more effective than if you give it after the insult. So in other words, if you give the steroids before surgery, they're more effective than if you give them after at the end of surgery, where you've done the insult. So it's the reason we'd start them. I'd usually operate on Tuesday, and so I'd start the steroids on Sunday. I'd give the patient a prescription, and they'd start the steroids on Sunday.
It's similar to what we do for some of the uveitis vitrectomy. We have them start a couple days ahead.
Yeah.
Use up the steroids. Dr. Winslow, are there certain medication-wise that you do differently, either periocular medication, intraocular medication, or parasurgical medications for PVR cases?
CC, I didn't fully understand your question. Do it one more time.
Do you use certain medication in terms of for your PVR cases? Do you use steroids? Do you differently?
We really haven't. No.
Okay. So,
I'd like to try this methotrexate. That interests me.
So for the speaking of which, the methotrexate, I think we finally have the site initiation has already been finished. And I think we're finally completely good to go in terms of enrollment. So we're part of the GUARD study, they call it, for basically intraocular methotrexate for the PVR. It took a while for the site initiation visit and the approval, but it's all good to go. But the inclusion criteria for that one, it's a little bit more stringent in terms of PVR. It has to be a repeat PVR. It can't be primary PVR. And it has to be basically, I think, about 3 or 4 clock hours of severe PVR, basically. The other part of the same study is post-globe detachment. So we think we can probably recruit a lot more in that arm than just severe PVR. But you want to comment on the methotrexate, Dr. Abrams?
Well, I think it's very exciting that the study's finally getting kicked off, but Dean Elliott's baby, Dean's published on use of methotrexate, and there's been a couple of series that have been published, not randomized. This is going to be the first randomized study for PVR. I'm sort of sorry they're not doing primary PVR as well, because I really think I think
you very well might be able to show a benefit for primary PVR as well. And I think it'd be easier to sort of grade the eyes and see success versus failure in the primary PVR better than re-op PVR, because re-op PVRs are just, they're awful eyes. They're just eyes, they're sick eyes that just, you have a success and we're proud of it, but often the patient is not, doesn't recognize all that much difference sometimes in the re-ops. Even if you get a great result, sometimes they just don't see very much. And maybe they will see more with methotrexate, though I have my doubts. I think they would have done better if they had included primary PVR.
And it's quite a significant injection burden. Basically, you're injecting either the day during surgery or the day after surgery, and you're doing weekly injections for basically 13 weeks of the methotrexate. I think their rationale is the duration of action is quite short for the methotrexate, so you have to keep weekly injecting them.
That's really the difference between this study and all the other anti-metabolite studies that have been done. All of the other studies have just given the anti-metabolite either at the time of surgery or right at the end of surgery, and then just waited to see if it had any effect. They didn't continue to give the medication. And so it really does make sense. If you're going to do it, you need to keep a level on board for during the healing process. And but this is the first study that's really looked at anti-metabolite like this and continued to give it over a long period of time.
Let's just quickly touch up on just general surgical approach, some key points. Dr. Abrams, do you always put on the buckle for most of your PVR? For severe PVR?
They already have a buckle.
Okay.
Very rarely would I change it. Occasionally I've supplemented a buckle, if I felt they needed more. I thought several times if I thought that supplementing the buckle, especially inferiorly, might help the patient, I would do it, but that was so rare. I mean, if they already had an encircling buckle, I'd leave it. If they didn't have a buckle, I'd usually put a 42 band around the eye, just supporting the vitreous base area, the area just at the vitreous base and just posteriorly.
Dr. Winslow, do you usually add on a buckle for your PVR cases if there wasn't one?
Yes, I would use a bigger one than that myself, but I'd probably use
Do you use
7 or something.
Oh, okay.
I used to do that. That used to be 287 or a 5x7 sponge for PVR used to be my go-to. But it was so much, after probably the last, 15, 20 years, I went to just a 42 band. And I felt it was plenty adequate for the PVR cases. I really went away from the big, broad, high buckle, which I used to do a lot. I kind of went away from that. And I probably became a little more liberal with retinectomy over time than I was years ago.
I'm certainly more liberal in that approach now. So I have a question there, and this would be hard to tell, and that would be an advantage with your 42 band. If you have, let's just say it's a very severe PVR, and you think ultimately you're going to need either a 180 or potentially 360 retinectomy, would you put on a buckle at that point? I sort of would not.
No, I wouldn't. If I'm going to do, if I'm going to do a in fact, I would put, the way I'd always do it is I'd put my buckle on at the beginning of the case, before I put any infusion ports in.
Yes.
Well, the eye was completely formed. I'd put my sutures in. I never use belt loops. I always just use sutures. Put my sutures in, put my buckle around, and I wouldn't pull it up yet. I would just,
Yeah.
just put it around. I'd put the sleeve on it, and then I'd pull it up at the end of the case. If I ended up with a 360 retinectomy, I just cut the sutures and
Aha.
take the buckle out. I wouldn't leave the buckle up.
Okay, that's a good way to do it. Okay, I like that.
What about in primary PVRs? Are there primary PVRs when you don't even put a buckle that you say you're definitely going to cut? Or do you always try to give a chance without cutting? Or primary PVRs?
Well, how many times do you do a 360 retinectomy for primary PVR?
That's why I was mentioning. That's why, are there cases, for primary PVR, I always put on a buckle, and I assume I'm going to be able to do it without cutting. So I'm assuming we're talking about more repeat PVR in the sense that you think you're going to cut and you don't put a buckle on, or do you always put a buckle, or you give it a chance?
There's a rare time that I'll already know we're going to have to do a 360. Maybe they've already had major retinectomy before, and I know I'm going to finish it off. I wouldn't put the buckle on, but usually I don't know that at the beginning of the case. It's usually that's a decision that's made during surgery.
Yeah.
And
I like your approach.
it doesn't take long to put a buckle around at the beginning of the case.
Yeah, I like your approach. That sounds good.
Yeah, so just for some of the fellows and everything, let's just in a general approach to your PVR diagrams in terms of the way I was doing it is just first I explore all the epiretinal components of the PVR, try to peel off all the epiretinal PVR as much as I can. And then usually I gauge, I don't really try to put perfluorine to test the retina or to see if it flattens. I kind of gauge whether I feel like it's enough just by feel. I don't know if people do it differently. And then if there are subretinal components that I feel will prevent the retina from flattening, I go for it. But if I feel like it'll just, not all the subretinal do I approach it. In fact, frequently the subretinal, we leave it. And then the final option is the retinectomy. And that's kind of my serial approach. Is that basically how you approach it?
Well, used to be, we would spend an inordinate amount of time trying to open up for example, many of these reops will have anterior retinal displacement or Steve Charles anterior loop traction. You'll occasionally see anterior loop or anterior PVR in a primary PVR if it's very, very chronic. If it's not chronic, I would say you will never see anterior retinal displacement in a non-chronic primary PVR. So, but what we would used to do is we'd have this anterior loop traction or anterior retinal displacement, and we'd spend an inordinate amount of time trying to dissect that loose. And, we would, Tom Auberg and Hillel Lewis had published this paper showing all these techniques of opening up of sectioning the membranes in the in the anterior PVR, of taking scissors and cutting along to release anterior retinal displacement and all of these various things. Inevitably, I found that I would end up with multiple retinal breaks anteriorly when I would try to do that. So after a while, after a few years of this, I finally decided that I would give it an initial, I would pay homage to Tom, and I would do a little bit of that. If it was clear to me that this was going to be a difficult dissection, I would immediately make a decision I was going to do a retinectomy. So if you look at my re-op results, which we published a couple of years ago, if you look at those re-op results, we did retinectomies in I think it's 85, 90% of the cases on these re-ops. And so I became very liberal in doing retinectomy in re-ops. In primary cases, though, I found that I rarely needed to do a retinectomy. Occasionally, if they're chronic and you've got a lot of anterior retinal displacement, you will have to do you will have to end up doing a retinectomy. But most of the time in primary PVR, what you do in primary PVR, what you end up getting, the vast majority of cases are going to have two types of proliferation. They're going to have circumferential contraction, where you've got a lot of organization of the vitreous right at the vitreous base and onto the separated vitreous, and pulling the retina forward, and you'll have multiple star folds anteriorly. And one thing you'll find, and I think it's one of the most interesting phenomena I've ever seen, is with PVR, if you'll notice when you're doing some of these PVR cases, you'll find when you do your initial vitrectomy and then you'll find some membranes and you'll start stripping the membranes, you'll find that the vitreous base, the vitreous is attached posterior to where the horseshoe tears are. That shouldn't be possible. The vitreous separates to the anterior aspect of the horseshoe tears, correct?
Mhm.
Yes.
Makes sense. Why would the vitreous be attached to the retina well posterior to the horseshoe tears? The reason is what happens is the vitreous marches posteriorly. What happens is the first place membranes form in most cases with PVR is at the inferior vitreous base. That's the first place that you'll start seeing some organization. So what happens is you get this fibrosis, the proliferation starting right there where the vitreous joins the retina at the vitreous base, and you get this fibrosis, and it gradually reattaches the vitreous and brings it more posteriorly just by the fibrosis. So what I'll do is I'll start the membrane peel, and then you'll often, as you peel the membranes, you'll see the vitreous will separate anteriorly to where it should be. You go to the original vitreous, you can get it, you can separate the vitreous usually while you're peeling the membranes. You can separate the vitreous clear out to the original normal location of the vitreous base. But what it has done is, with the proliferation that occurs at the junction of the vitreous and the retina, it gradually reattaches vitreous just progressively, extending more posteriorly. And one of the things that you'll do in a primary PVR is you try to get the vitreous base back to its original location. And that happens during your peripheral membrane peeling. And one of the hardest things I notice for fellows to learn is when you're doing PVR surgery is the initial finding the membranes. You can have this, it'll look like you've got this smooth surface, and there's all kind of membranes, the retina's all contracted, but you're sitting there, you're scraping, you're doing this, you can't find the damn membranes. And then what I would often do is I say, okay, let me in there. I go in there and, in 2 or 3 minutes, I'd have a membrane up, and I always called it the key. The first membrane that you get that comes up. That's the key, because you get one, it's going to lead you to the next one and the next one, and it just goes on and on. They're all interconnected. You get, and I usually try to start posteriorly and go anteriorly. I rarely start anteriorly and go posteriorly. So you'll peel the membranes posteriorly, and then you find that first membrane or two, and then everything starts opening up, and then you'll be able to peel. And then as you get anteriorly, you want to, once again, you want to take that vitreous back to the original vitreous base. And a couple of things that I do would be you'd sort of grab the vitreous, and then you'd sort of peel in between this vitreous, sort of pull it forward, and it'll just gradually grab it and kind of pull forward, and it'll continue to separate it out to the vitreous base. But your goal needs to be to get the vitreous to its original, the normal original vitreous base. And that would be, if you got horseshoe tears, that would be at the anterior aspect of the horseshoe tears, because that should be where the vitreous base is.
What do you do with the lens if it's phakic, in phakic PVRs?
Well, I'd be interested in everybody's thoughts on this. I used to, when I'd give a lecture, I'd always say, I'd always remove the lens, because I didn't feel I could do an adequate vitreous base dissection if there was a lens present. But when I converted 25 gauge, I found that I could work around certainly the inferior, most of the inferior 180, I could dissect using a 25 gauge instrumentation. I could work around the lens and I wouldn't bang the lens. Using 20 gauge instrumentation, I would 100% of the time, I would end up banging the lens if I tried to do a good vitreous base dissection. So I think you can do a pretty good vitreous base dissection using small gauge vitrectomy. So I was less likely, if you had a clear lens, I would usually just go ahead and leave the lens and do it. If you've got any degree of cataract, I'll go ahead and take the lens out. I usually did not put in an IOL, because in PVR you'd end up with synechia of the iris to the residual lens capsule, and it often would create more problems. With PVR, especially with any severity of PVR, your goal is to save the eye. It shouldn't be to save the lens. And now with the techniques that we're currently using, that CC has become a true expert at, you can later go in, and if you get a good visual results, you can go back in and suture in a PCIOL, scleral fixate it like CC does. And so, I would usually if I tried to put in a lens at the time or anything, I usually regretted it because of just the inflammatory changes you see following the vitrectomy.
Dr. Winslow, how do you treat your lens if it's a phakic PVR patient?
I would usually leave it unless during surgery I had a problem, but I wouldn't preemptively remove it.
I think that's what I think earlier on I was more into just taking the lens out for a while. And then recently, I think in general, same as with diabetic cases, I try to leave the lens if I could work with the lens.
Yeah.
We have, I think Anthony is going to present a case where this is the eye we left the lens, I think. And it's the same detachment, same PVR in both eyes. And one side, the first one, it's a clear lens. We took the lens and we did a dissection. And then the second one, we just did it, keeping the lens in. And the eye with the lens in seems to do a whole lot better.
Well, you're going to get a cataract in
you know, with PVR surgery, you're going to end up ultimately with a cataract in
Yeah.
100% of the cases. But you know, the eyes do a lot better with a good PCIOL in the bag than they're going to do any other way. So, I mean, if you can, you know, if you can do the surgery and leave the lens, that's the best way to do it.
More
It's
recently,
a lot easier with the small gauge instrumentation though than when we used to do 20 gauge. Inevitably, you'd bang the lens with 20 gauge instrumentation.
okay, let's go to some videos. Well, since we just mentioned Anthony, do you want to share your video?
Sure. Yeah, if you can just.
Yeah, I stopped sharing. And it's multi, everyone can share, so you should be able to.
I think I'll have to make him a co-host.
Oh, I already enabled so everyone can share. So
You did, okay.
All right. Okay, yeah, so Dr. Lin mentioned this was a patient who we actually have 2 eyes of experience with. It was a 25-year-old female who has some developmental disability and may have had, I believe, some self-inflicted blunt trauma or at least delayed presentation because of inability to kind of communicate the visual complaints that she was having. So when she did present to us, we found her to have bilateral, basically grade C PVR, 12 clock hours of fixed folds OU, and generally a closed funnel type configuration. Her other eye had been repaired.
Hey, did she have Tourette's syndrome?
She does not have Tourette's.
Okay.
I'm not sure the underlying diagnosis specifically.
Yeah, we've had several Tourette's syndrome with self-abuse that where they couldn't help it. You know, I mean, they start hammering at their eyes. I mean, it's bizarre. Watch it.
Yeah, I've seen, I think I mentioned to you actually even before going into medicine, I worked with some folks with developmental disabilities, and we had one person who kind of compulsively hit themselves in kind of the right frontal region, so much so that they developed like chronic hyperpigmentation of the skin because it was just that one spot that they would always hit. So yeah, in her case, like I was saying, she had the other eye repaired, I think about a couple weeks or a month prior to this surgery. And I wasn't in on that case, but I know she did have kind of a different overall strategy. Basically, the lens was taken and a retinectomy was performed. In fact, she was one of the patients that had some intraoperative displacement of the retina after retinectomy that then led the surgeons to complete the retinectomy to relieve kind of the traction that was pulling retina up towards the area of attached or left retina that was left, I think, superiorly. So in this other eye, we basically decided to go ahead and leave the lens in and make this full screen. We placed, I believe, a 42 band around this eye and then went in with our vitrectomy. You can see lens relatively clear here, although there is some vitreous haze, and you can see, you know, pretty significant amount of PVR, fixed folds. Can't see the nerve here.
in terms of instrumentation, the gauge of vitrectomy, do people like to use 23 gauge, 25 gauge? Dr. Winslow, do you have a preference, 23 versus 25 for PVRs?
No, not really. Usually would use a 23, but
You know, I went through a phase where I was using 23, but then when they stiffened the proximal part of the 25 gauge cutter, we just started using 25 for everything.
You to start the dissection for these membranes, is there an instrument of choice that do you just pick at it with a forceps, use a pick, or how's your approach in terms of starting these dissection?
I'd say either. Say whatever works. I'd often start out with the forceps, but if I wasn't getting good, I would use a pick.
Cece, what forceps do you like? Do you like that one you mentioned before?
Same forceps. I usually, if I could see, usually like these were when they're in the loop configuration, if I could find that ring posteriorly where I could catch onto with the cutter, that ball of vitreous that you could catch onto and just start sucking and pulling it back to get the initial, basically that vitreous, the vitreoretinal adhesion Dr. Abrams was talking about, get that up. And then I will explore individual membranes underneath that, if there's star folds or anything underneath. And I'll use the same forceps. And basically, the same way I try to pinch the IOM on a detached retina is basically I pinch it, and usually you get a feel in terms of usually what I end up doing when I'm pinching these detached ones is you really have to push down. Basically push it down until you see the change of color of the RPE when the retina is touching the RPE. And when you grab that, usually you either catch most likely you're catching the epiretinal component of the PVR. In a case that doesn't have PVR, when you pinch it like that, frequently you can catch onto the ILM. But
I had rewound the video a bit because in this case we did. I was able to get that initial kind of membrane off using just the cutter on aspiration near kind of the posterior aspect where the funnel closed. And then this was earlier in my fellowship, so I don't know if this is you or me, but I think maybe you at this point in using those Tuari T2 forceps to kind of advance that leading edge that you had. I think this patient actually, I believe, had some hemorrhage at one point here during the...
Do you use any staining at this point?
Just triamcinolone, I think. For the detached one, unless there's a macular hole, even in a macular hole, I'm a little nervous with too much IC green going subretinally. So most of the time, kind of that hyaloid, I find once you get, you can get the edge with the forceps, but if it's kind of immature PVR or immature or kind of hyaloid, cortical vitreous, you're probably better off using a gentle aspiration of the cutter to extend that. So I think, Anthony, remind me if I got it wrong, but this case is similar to a lot of these kind of funnel detachment in the sense that initially there's that ball of vitreous posteriorly holding everything together. And that frequently you could just catch it with suctioning.
Yeah, that's what, when you guys were talking about starting the dissection, I had kind of rewound it to here where just using the vitrectomy cutter, we were able to bring up that kind of initial ring at the area of confluence of retina there. And then that did start to give us an edge and kind of relaxed the retina. But beneath that, there were also significant epiretinal membranes that had to be brought up as well, for pretty much from the macula moving anteriorly.
So it looks to me like you've got just, Anthony, it looks to me like you're just pulling up a plug of condensed posterior cortical vitreous there.
Yeah.
Vitreous wasn't separated in this eye.
That's right. And
I don't know
then,
this, but if you've got an eye that's already had a vitrectomy or an eye that's had a PVD, you're going to have to either use forceps or a pick to get the membrane started. You're not going to be able to do it with a.
No, not with the vitrector.
I agree. I've
Yeah.
never had a PVR case that I could peel anything off with a vitrector. You gotta get forceps in there.
Yeah. No, what I meant was more the cortical vitreous. If you, not necessarily in the PVR cases, but some of these cases where you have vitreoschisis and your whole cortical vitreous is down, even though it looks like a PVD has been, like these situations, like right here.
here's a little bit of bringing up some of the membrane here with the cutter tip, but yeah, probably.
Yeah, you're separating the hyaloid anteriorly. It's just not, it's membrane and hyaloid that you're separating there.
So Dr. Abrams, usually when we separate those, in terms of the anatomy of PVR, once we separate that layer, are there generally still membranes underneath that? Or generally, once you separate that layer, it's continuous with the membranes?
Usually there's not more membranes. Usually you get the membrane off. Sometimes you'll have edema of the retina. You can have some thickened inner retina that can look like membrane, but usually there's no longer membrane. When you pull the membrane off, usually there's not more under it.
So that layer of kind of semi-fibrotic hyaloid, that's usually at the same level as the membranes.
Usually.
Okay.
But you got to be careful. Sometimes, especially if the hyaloid, as I was saying, is reattached, you can have hyaloid and you can still have membranes under there. So, but if it's a primary case, usually it's all going to be together.
Okay.
Gary, aren't those, like that case that was just presented, aren't those more favorable than if you have a lot of anterior PVR? My understanding and my experience is that anterior PVR is often harder to deal with than that posterior PVR.
Absolutely. I fully agree.
Because they look bad and you can't see the disc, but you can usually get down in there and peel that all up, anyway, it seems to work out more favorably in most cases than.
Yeah, you'll rarely, if ever, have problems with hypotony. That's a problem of anterior PVR. Postoperative hypotony.
Yeah.
You never see that with posterior, with just that pure posterior PVR.
For clarification on the nomenclature, when we have, the PVRs where it's basically, it's a very fibrotic proliferation at the vitreous base, and you have that loop, very tight loop configuration. That's considered anterior?
Yes.
Yes.
Okay. Is that, I'm just trying to clarify, is that what we're talking about? Like where your vitreous space is fibrotic and contracted, those situations?
Those cases are terrible, I think.
Well, it's all, sometimes when you've got pretty much a pure, you have some posterior PVR, and then you've got pretty much a pure circumferential contraction, where the contraction is at the posterior hyaloid and it's pulling the posterior aspect of the vitreous base centrally. Mm-hmm. That's the circumferential contraction. You may have some, folds, some epiretinal membrane folds, star fold type things, just on the posterior edge of it. You peel that off, and then you trim the vitreous back, clear to the vitreous, to that posterior edge of the vitreous base, and just try to relax it. And then if you got a buckle under it, very often you'll completely neutralize the traction, and those can be very favorable cases. So they aren't necessarily bad cases. Some of those are the best cases.
I think, Dr. Abrams, you like to use a lighted pick and a forceps to release those
Now,
circumferential.
my favorite was always a relatively blunt illuminated pick. You know, they made an illuminated knife and illuminated pick. The illuminated knife had a sharp edge on it, a pointed sharp edge, which I never liked for PVR because you'd keep catching the retina with it and you'd end up with creating new breaks or get a hemorrhage. But the rounded off blunt tip illuminated pick was wonderful for PVR because you just kind of run that up a fold and it would catch the membrane, but it wouldn't catch the retina and it wouldn't tear the retina and you could engage the membrane. The other
Hey,
end,
Gary, it's Deepa. Hi, sorry, I was in clinic up to now. This rounded edge pick, do you use it to engage at the beginning, or do you create like a little entry into the membrane first and then use your blunt pick?
what I would do is there's the old pick forceps, and they make actually a small gauge pick forceps. I think 23 is the smallest one they make, but they make a 23 gauge pick forceps, which was really pretty damn good because it's got both a pick and a forceps. And the forceps is pretty good. It'll hold the membrane quite well. And it's got a pick on it. So you've got both a sharp pick and a forceps in one hand, and then you've got the illuminated pick in the other. And you can, you know, many times the first place you'll get the membrane is by, say you've got a star fold, or say you got a diffuse contraction that's multiple star folds. It'll have these 6 folds radiating out from the membrane. What you can do is you just either get your pick forceps or your illuminated pick, whichever one seems to fit the best, and just put it in the membrane and peel toward the center of it, toward the membrane. And you'll end up engaging the membrane and you'll elevate it. Then you can grab it with your forceps and end up separating it from the retina. And usually when you do that, all at once another membrane will open up next to it and it'll be one after the other and you peel the whole thing then.
Oh, you know, on a similar technique to what Dr. Abrams mentioned, you know, when you have the circumferential contraction and your goal is to just relax the contraction circumferentially, I end up just putting a chandelier and use two max grips. I think the case has some of that. Basically the same thing. I just find it keeps falling out when I'm using the pick. Sometimes it just shreds the membrane a little bit. Sometimes it just doesn't hold it strong enough. I end up just getting 2 max grips and you just go inferiorly, grab that fibrotic contraction and just kind of go sideways. And you have to use a little muscle to pull it apart, but you could actually feel it kind of shredding sideways. And then you just see that subtle relaxation.
Yeah, that's a wonderful technique. That's a beautiful technique. That really works well.
Yeah.
Sometimes you can do that with your pick. You know, you'll kind of stab the membrane, split the membrane, and just repeatedly, you know, you grab the membrane with forceps and you'll take your pick and split it, and just continue doing that repeatedly, and it'll do much the same thing. But the 2 forceps technique is a wonderful technique. It really works beautifully.
Did you guys talk about yet viewing, posterior viewing? Do you find that the biome is sufficient, or did you ever use those prism lenses, stuck-on lenses, you know, for the really peripheral membranes?
I mean, I just use biome. I mean, the only time I stick on a contact lens is just for posterior. If I'm trying to, for most PVR cases, I think I just end up with the biome most of the time. Maybe if I'm trying to start a membrane or trying to explore the hyaloid, I may slap on a contact lens for posterior. but other than that, you just stick with the biome.
I would often use a contact, when I'm working right at the posterior pole, right around the macula.
Yeah.
But the rest of it would all be with the biome.
I've used those prism lenses and they're not nearly as good as the wide field viewing, I think.
When I was in residency in Long Island, Phil Ferrone was doing bilateral ROP detachments. So he had quite an interesting array of imaging techniques, including the prism, but also the, what was it called? The Avi irrigating contact lens.
Yes.
You ever used, have you used it yourself?
I used it, I tried to use it a couple of times when I first graduated, and I really couldn't see the advantage like over a longer period of time. I just found that I was so much better with the biome. And now, of course, we have the biome here with the Leica, and in Windsor, I have the what do you call it? The Zeiss microscope, the Lumera. So that has the high mag lens and then the peripheral lens. And that's a nice option because you can just switch without, changing the lenses or whatever. You just flip that lens into view. So you do have the option of having a little bit of high mag in the areas that you think would help you, and then you can switch back to your peripheral to get a better idea of what's going on past where you're peeling.
Well, I used the Avi lens for 2 or 3 years before we got a biome. For years, I used used prism lenses. You'd sew on the little holder, and then you'd use various prisms. It had a posterior and then a mid peripheral and a far peripheral prisms that you could use. And it works. It's harder to use and the view's not as good, but you get used to it. You can do some pretty good surgery with it. I certainly did it for years. Then the next thing I used was the Avi lens. And I used the Avi lens for 2 or 3 years. I actually I was at the academy and I bought my own Avi lens. So it was one of those things in the OR that was marked Dr. Abrams lens. And so anybody—
Is it still there? Can we use it?
Maybe. Look and see. It might still be there. But it's much harder to use than the biome. But one thing I can tell you about the Avi lens, the videos that you get with the Avi lens are markedly superior to anything else that you can get in vitrectomy because the view is so crystal clear. The problem with the Avi lens is that you get a lot of prismatic effect when you move the eye around. And so until you pretty much have to learn to do everything leaving the eye exactly in its central position. Because if you then, typically with the biome, you'll move the eye all around and, the biome works just fine because you're just looking through the pupil. With the Avi lens, you move the eye and then you tilt the Avi lens when you move the eye over, you get this prismatic effect. So it took a while to get used to the thing. But once I got used to it and I would just basically be able to do everything and holding the eye pretty much in a central position. I got pretty good. And the Avi has such a wide field that you're basically looking at the aura with it. And it works really well. So,
but you need a good operator though, right?
The thing about the Avi lens is it's an East Coast thing. A lot of people on the East Coast still use Avi lenses. You don't find them any place probably west of Philadelphia. Everybody, the rest of the country went to the biome.
And is this Stanley Chang's Avi? Yes. Is that that Avi?
Yeah, Avi Greenblatt. Avi Greenblatt was Stanley Chang's. He was he did the videography for
Stan Chang, and very smart guy. He invented the Avi Lens, this wide angle lens that Stan used. I think Stan still uses it. You've seen Stan's videos. They are the absolutely crystal clear, beautiful videos. You cannot get that good a video with a biome. It's just not as good. But the biome is so much easier to use. You can move the eye around. You can do anything. Anything you can typically do with an eye, you can do with a biome. You can't with the Avi lens. You got to keep the eye pretty well fixed, because when you start tilting, you get all this prismatic effect that makes it gives this really weird impression. So it took me a while to get where I could use it, but I used that for probably 2 or 3 years before we got the biome.
I just remember getting yelled at as a PGY3 for not holding it straight.
Yeah, well, you tilted it and you gave him prismatic effect.
Actually, Chris Adam is using contact lens, I think. At least some of his cases, he's using the Avi lens.
Yeah, probably Avi.
Yeah.
That's it. Once again, that's East Coast. You got to use the Avi lens if you're in New York.
Yeah.
It's expected.
Anthony, you want to keep showing, or is that basically it?
Pretty much it, but yeah, I can say, Dr. Yoganathan, I've also had that pleasure of holding the Avi lens as a first-year resident, and it's harrowing.
New York City.
Aren't you glad that you're in biome land now?
I'm never going back. Yeah.
I wouldn't either.
Right, we can move to our next video if you'd like.
You want to share yours?
Yeah,
Rick,
sounds
did you ever
good.
use the Avi lens?
Me? No, I've never seen one used.
How about you, Rich?
I've never used it. But when the biome came out, I thought I'd died and gone to heaven.
Yeah. And the learning curve, there is a little bit of a learning curve with the biome if you've been using contact lenses, but it's not very long. I mean, it's pretty quick. When I first started using the biome, the hardest thing was learning to focus the damn thing.
All right, so this is a PVR case I did with Dr. Lin about a month ago. So 61-year-old lady came in. She was originally told by Heritage Optical that she had some retinal changes back in November. And then in May, she noticed her vision drop. She wasn't able to get in to see us until August because of COVID, and she was kind of scared to come and see anyone. When she presented, she had count fingers vision on the right. She still had maintained pressure in both eyes, and she had an APD. The view was roughly 300 clock hours of synechiae of the lens to the iris. So we had no view, so we have a B scan, which basically just shows this kind of open esque funnel attachment.
Since you mentioned it, these detachment, chronic detachment with, evidence of anterior segment inflammation. Does anybody go chasing down a uveitis, or just presume that's the inflammatory changes from the detachment? Where this lady is semic all the way around 360.
I think that's just from the detachment. I've never done any uveitis workup for those, but I remember one Grand Rounds case. It was presented as a uveitis, and it was a detachment, and no one. Cece, you might have been there. Anyway, no one believed me. I said, that eye is detached. That's the whole deal. And
They not done an ultrasound?
it was presented without an ultrasound, but I could see the pigment granules, behind, through the lens and whatnot. I knew it was detached, and ultimately it was, but it was presented as the uveitis.
I at the very beginning, I think I sometimes was worried that maybe it's whether there's a herpetic, arm that had a break and became detached. But I think more recently, the past year or so, anything that looks like that is with inflammatory changes, I just presume it's the detachment.
Were there KP? Were there KP?
I don't think,
I'm trying to remember.
I think
I
she
think that,
has a little bit.
yeah, it might make not a lot. The eye was just overall fairly hot, but I don't think there was significant KPs.
If I saw a lot of mutton fat KP,
Oh, yeah,
I would think long and hard about
yeah,
it.
that would be a little different. The
Yeah.
other thing
Yeah.
you'll get sometimes with this,
Usually you don't, you may have a lot of pigment precipitates, little tiny pigment precipitates, but you usually don't have actual, large or certainly not mutton fat KP with these. It's an inflammatory reaction secondary to the chronic detachment. And, it's, you don't end up with a lot of KP in these eyes. So that would be one thing that would move me toward worrying about uveitis, is if I saw certainly any mutton fat KP.
Or if they're heavily cellular, the AC for these are generally, you also have synechia and things, but they're not.
A lot of flare.
Yeah, but they're not like very cellular generally.
the other thing you can get is sometimes iris retraction syndrome. That's another telltale sign that there's a detachment back there. Have you seen that, CC?
I don't think I've seen it.
Yeah, the iris will be pulled back and the anterior chamber will be very, very deep.
Oh, with the anterior loop PVR, that's basically stuck all the way, pulled all the way to the iris.
No, no, no. They'll have posterior synechia, and basically the eye will be a little hypotenuse, and basically there's more fluid going out of the back of the eye than the front of the eye, and so the iris will be pulled back.
Okay.
Look it up, iris retraction syndrome. It's been well described.
Yes, those are all really good thoughts. Like you guys were all, like everyone was saying, this seems more, and the presentation was definitely more in the setting of inflammation secondary to this chronic detachment. So basically the patient got boarded for everything short of a left. We were doing synechiolisis, cataract, scleral buckle, vitrectomy, membrane peel, endo laser, and silicone oil.
So these I do take the lens for. I've tried before to just lyse the synechia and do the case. It ends up I couldn't finish. I end up having to take the lens.
Once again, this and I, you're just trying to save the eye.
Yeah, exactly. So we started with the scleral buckle portion. We actually went with a smaller, I believe we went with the 4172, 3.5 millimeters behind the muscle insertions. And then we started with our synechiolisis, cataract extraction. Just like one pearl from this is just starting the rhexis outside of the ring of pigment was really helpful to get started. It gives you a little bit more space rather than pulling through the scar tissue of pigment on the anterior capsule. That was kind of the one takeaway I learned from this step of the surgery. And you can kind of see that the anterior capsule is moving a little bit, just to kind of demonstrate not great capsular support, but overall the cataract surgery was fine.
One thing with even though we're doing a primary lensectomy, we're not leaving a lens or taking out all the capsule. I do still like to approach these from the anterior segment. It's just, for me, and Brett, same thing, that it's just a lot quicker getting the lens out. Getting the it's like 7 minutes or so. Compared to a lensectomy, I feel it actually takes me longer.
Yeah, especially in this eye, it wasn't a super dense lens. Going back to the video, it was a 5-10 minute cataract portion of the lens, doing it from the anterior phaco approach. But then we did have to go back and take the bag. We just don't want to leave anything that can be pro-inflammatory or give anything else an option to synech down or scar down. So we're using a nice technique of just using the blunt end of a Q-tip to really scleral indent and visualize the ciliary processes and get all the way out and get the bag all the way to the ciliary processes. You just have to be careful that they do bleed if you nick them, which I don't think I did. But it just really helps you visualize the whole bag. I think Anthony and Dr. Ritta did a glaucoma case, so they actually use a similar technique like this to do ECP on a patient.
Dr.
It's
So
something Dr. Lin had kind of talked me through ahead of time, so I think you had done it as well. But yeah, using the endolaser probe to basically photocoagulate the ciliary processes, seems to give you a few millimeters of mercury of lowering.
I thought we were doing something new, but Dr. Abrams says they've been doing that a long time ago.
Well, the first time, let me just tell you, the first time I ever did that, we got the second production endolaser unit. When I was in Milwaukee, we got the second commercial produced endolaser unit ever produced from HGM. That was the company. And Jay Fleischman and Manos Schwartz were the ones who invented it. And so HGM, and so Tom Aberg was able to get the first production unit. I think Jay got the first one and Tom got the second one. And I got this patient referred to me from Johns Hopkins to see if I could laser the ciliary body at glaucoma. And so we did a lensectomy, and I did exactly the same procedure you just did. That was in probably 1983. So.
All right, I'll have to take back the paper I was about to submit describing.
So it works really nice. So here, as we're getting into the eye, you can see there's pretty decent kind of grade D PVR with this fairly open funnel configuration.
Sorry
and
to
this large...
interrupt, Brett. There was a applicant online, Justin. Justin, are you still there, or did you leave? We had an applicant online who had asked a question. He just wrote that he had to leave for a second, but we should probably reach out to him after and just say thanks for joining. Okay, sorry to interrupt.
I see his. Oh, no problem. All right, so this is also kind of just that posterior, well, I guess we skipped over it, but you can kind of see like that posterior ball condensed vitreous that kind of comes up here as well. And then we kind of just start with the cutter using an aspiration technique to pull off any of that, any of the membranes that are kind of on the posterior vitreous face here.
That's probably not the PVR membrane. That's probably just the what Dr. Abrams was describing earlier, where the hyaloid kind of contracts down again.
Okay.
Exactly what Dr. Abrams was talking about, where in this situation, the horseshoe tear is all the way up at the vitreous base, but the hyaloid, basically, the bulk of the vitreous is again kind of glued back down into kind of that open funnel.
Okay.
Progressive contraction of membranes at the junction of the vitreous and the retina that gradually pulls that hyaloid back and just gradually reinserts it to the retina.
Okay.
It's attached sort of to the membranes.
Okay. So yeah, that's kind of exactly what we're working with right here.
Look, it's horseshoe tears. There's no way that you'd expect that your vitreous would still be attached back there, is it?
Exactly. So we kind of went 360. We were able to get the vitreous return to the almost, level of the vitreous base. And now we're kind of just exploring, with the cutter, are we able to engage any membranes kind of right off the bat, as, we already have the cutter in the eye, and we work our way around. And then we'll get into a couple of different techniques that we use to actually peel the membranes, I think, in the next couple segments. Oh, and then we just kind of came to the horseshoe tear, just made sure all the traction was released. Make sure the vitreous base was released to the level of the horseshoe tear.
Dr. Winslow, is this kind of that anterior contraction you're talking about?
Yeah, that starfold there, yeah. Those are, I think, a little harder to work with, I think,
Yeah.
than that first case you showed.
Then those closed funnel where it's just a ball of vitreous inside.
So then now that we've kind of got the vitreous base up, now we'll start our peeling. Originally, we just start with just the max grip forceps. Now that I've gone back, I guess we'll find it here in a second. So we start just with the max grip forceps in some of these areas of the star fold. We have a little bit of luck just with kind of a unilateral forcep light pipe technique by grasping the membrane with the forceps and then using the light pipe to kind of almost peel underneath it to try to create some space. But as we see, we're clearly not getting, enough. We don't have enough power with just that motion. So now we're kind of moving into the dual max grips, where you can kind of grab either end of the membrane and kind of pull them apart to break open these areas of folds.
So you've got the 27 gauge chandelier at 12 o'clock.
Yes.
Yes.
That's a great.
Yeah, so we transitioned to a chandelier pretty early in this case.
Really a good chandelier.
Yeah, it's quite nice. Really provides a nice view. And we switched pretty early. I mean, we knew we were going to need a bimanual technique. So we kind of worked our way around.
Did you use two of the same forceps, or different sizes, or different types of forceps?
We used two max grips. In this case, I know I've been talking to Dr. Lin, who can correct me otherwise, but I know the two forceps that we tend to use a lot are the Tuari T2s and the max grips. The Tuari T2s tend to be a lot better for like macular work, whereas the max grips they're a little tougher. So when you have these really dense membranes, they allow a little bit more pulling power.
And 27 gauge or 20?
I think we were 25 gauge for this case.
Yeah, the T2s are good for exploring, like you can pinch with it. But these, I feel like for PVR, when you're actually trying to work on with heavy membranes, these are a lot stronger.
And so kind of we worked our way kind of around here, 360, working through those star folds, kind of peeling them apart with this bimanual technique, kind of the grip and the peel apart, which worked really nicely. And then once we get some of these open, then we do switch back to the bimanual technique of a vitrector and a max grip forcep. And so the max grip forcep can kind of create a small area of space, and then you can use the vitrector to get into that space. And kind of using a similar technique as what we were doing with the light pipe, kind of using the rounded edge to create a little space and a counter traction to the max grip pulling.
I think this is the one Dr. Abrams says where you can just use the second instrument to kind of tease it apart, tease it. It's good for separating your vitreous, if everything is contracted more posterior, separating it to the vitreous base, I think.
Yeah, you can grab the membrane and then stab it with the pick, the illuminated pick, and then just split it in two, and it'll pull apart, and it'll relieve a lot of the traction.
Okay. And then we did a little macular work. We went under macular lines with Kenalog. and just to make sure we were able to release the membranes in the macula.
So I don't really know which layer this is actually. When I'm peeling, it's acting kind of like cortical vitreous, but you know we kind of separated that layer, you know, that ball of vitreous earlier. So I still think this is probably a little vitreoschisis, and this is probably still cortical vitreous.
That's what I would say.
Yeah, the other thing is it's pretty inflamed eye. Could this be a little coagulum that's formed on the retina surface?
Yeah, I'd say I run into this pretty often with PVR, where you kind of, when you put the Kenalog down, you'll see this these multiple layers of what looks like cortical vitreous. And I often wonder what that is. I wonder if it's just immature PVR, but what I found is the better I peel it, the less post-op ERMs I get. So maybe it's just immature PVR.
Yeah, these we were talking that these, even for your primary RRDs without PVR or with no obvious PVR, that if you just stain and explore the membrane, a lot of times you get this layer. In fact, we were just reviewing this paper that's showing a significant amount. You know, I think it's somewhere north of 50% or so. That you, in a classic horseshoe PVD associated detachment, that you get this additional layer.
Would you be able to get enough of it to look at this thing?
I mean, I think it's cortical vitreous. I mean, it's you're hard to get a whole sheet of this.
Yeah.
That's why I say you kind of can start it and then you use a cutter to aspirate it. Use the aspiration to separate it. It's easier than trying to grab it with forceps. Everything is just shreds.
Can we talk a little bit about general approach to these early PVR cases, whether it's primary RD or recurrent RD, and you know that there's like a layer of something, but it's not enough to actually peel a sheet. And what I do is I'll take a Tano, a diamond dusted membrane scraper, and I'll just keep gathering these cells, like, you know, wiping the cells off and trying to release whatever traction the cells have on the retina with the help of some Kenalog, and just keep wiping and wiping in that general area. Is there evidence, like, is there any evidence of how certain methods may work better than others? Or with early PVR, is it just that you kind of have to wait till the mature, I mean, obviously you're operating, but you won't know what the outcome will be until the mature PVR develops or not develops down the road?
I think you're talking about immature PVR, and you know, I was never a fan of waiting and letting the membranes mature. I think the membranes mature and the photoreceptors die. So I think it's better just to do it. And you know, I actually I think the flex loop works better than Tano. Tano seems to scrape the retina a lot, and the flex loop seems to be a little gentler on the retina, and it'll still get a lot of this, you know, this immature debris that builds up on the retina. It'll get it off pretty well.
And what did you use before the Tano and before the flex loop?
The first thing I ever used was a back flush brush, you know, where, you know, the back flush brush the tip on it had multiple little cuts in it, so it was kind of like a broom.
Yeah, that's how I trained. Our back flush brush was how we did all our air fluid exchanges, and it had those cuts in it.
Yeah, And that will work, but it doesn't work as well as the Tonneau or the Flex Loop. And I thought the Flex Loop was the best. What do you use, CC?
I use these forceps. I use these, I use these forceps, and I start, and sometimes you get the beginning of a sheet. Most of the time when you try to peel it, grab the sheet and try to peel it, it'll shred. But then at that point, I switch to just a cutter and use the aspiration of it to gently aspirate that edge of the sheet onto it. And frequently you could start separating it.
Yeah.
You can start separating some sheets of it.
Dr. Chapman, what do you used to use before the Flex Loop and Tonneau brush?
I used to use a bent MVR blade to explore every square millimeter of the preretinal surface. And if I could get an edge, as tiny as it may be, then I would be able to at least get something started with forceps. But when I had these sort of extremely difficult membranes, I just took forever with the MVR blade.
So you take a bent MVR and you blunt the tip so it's a little bit of a pick, and then you just keep exploring.
Gently scrape, yeah, come down tangentially and scrape.
Yeah, I think if you're going to use the bent tip blade, one thing you want to do is you don't want to be peeling with the tip of it. You kind of use the side of the bent part, and I think that's probably what you meant by tangentially. You just kind of use the edge of it rather than the tip of it. The tip of it of the MVR blade tends to keep catching on the retina.
Yeah,
and
with a bent MVR, you touch down on the flat.
nicks in the retina. If you use the edge of it, you can kind of glide along the surface of the retina without catching the retina.
Yeah, I would bend it and then touch down on it and then dissect, even side to side if I could, or if I thought I had the edge, then I'd pick it with the point. But very tedious. But
You know, I always found that the original MVR that we would blunt ourselves had something that made it better to catch these membranes or peel these, or scrape off these membranes better than the pre-made picks, where the prefabricated picks. Was there something about the tangential sides of the original MVR that are different from the pick MVR that was pre-made for 23 gauge and 25 gauge?
well, I think it was proprioceptive. It was pretty stiff relative to the smaller instruments that we use, and I just felt I had better control on the retinal surface.
Oh, interesting. So just the bulk of the size gave you more feedback.
Sure.
I always thought the picks were too blunt to engage the membranes myself. I mean, if you got it elevated, then you could use the pick to get in under it, but to start it, I didn't think they would engage the membrane.
Yeah, exactly. They were just too rounded, but the original MVR was much better.
Remember the old Rich? You remember the Michaels picks?
Yeah, oh yes.
There were 3 Michaels picks. They'd come in a set. One was a right angle, one was an acute angle, probably something less than 90 degrees, it's kind of bent in on itself so you could hook something and pull it. And then the third one was a spatula. And supposedly you could use them for whatever type, thing you were doing with it. I thought the Michaels pick was pretty good. You could put it in, it was good if you had a fold, you could put that right angle Michaels pick in a fold, and it was not so sharp that you'd catch the retina. You could just glide through the fold and catch the membrane and pull it out. And I used to use that a lot, but then I switched to, for that maneuver, I switched to illuminated pick, and I sort of abandoned the Michaels picks after a while.
I had to use Michael's pick a couple of times to engage a PVD when sometimes you can't suction that PVD off the nerve. I would try to engage it with a Michael's pick.
There's still a Michael's pick on the tray. I think it's been used more for some of the complicated anterior segment surgeries for manipulation of the iris and the lens. So don't throw it away, because it's a neat tool when you get a chance to use it on the retina.
I would tend to agree with Cece, though. I think the forceps still work better, even in these mature ones, sort of immature, I'm sorry, membranes, rather than the Tano or the flex loop. I haven't had much luck with the Tano or flex loop.
Brett, you want to continue?
Those are all really good thoughts, because a lot of those are tools I haven't had the opportunity to use yet. So we were able to get kind of a little sheet here and do a decent peel. And now we kind of came back to our buckle and adjusted our buckle height.
Scientifically adjusted the buckle height.
Scientifically, exactly.
I was going to ask you if you measured 6 millimeters on that, or just pulled it up and looked.
Just pulled it up and looked. And then we were able to put PFC in the eye. And kind of after all of our work, we did, so that we had the original break, and then I think we had 2 small, or 1 small, 1 decent size iatrogenic breaks as well. But they actually all sat on the buckle pretty well. And so we got the eye under PFC, we got everything flat. Then we did 360 endo laser on the buckle. And then we knew we were doing silicone oil, so we came back to our AC and just made sure that we put our PI in, especially under the guise of, leaving the patient aphakic. And then this is actually a conversation that
You stop.
Make your PI before you go to air.
Okay, good.
Yeah.
It's a heck of a lot easier to make your PI under fluid than it is under air. I would always forget. And I'd say, oh crap, I forgot to make my PI. Then I'd have to make my PI under air.
Yeah, the other thing is, I think you need to make those PIs very generous, because they tend to fibrose and close off
Yeah.
with oil.
Yeah, Dr. Lin had made that recommendation. So you can see how I started the PI, and then you can see halfway through the video, CC is kind of coming in with the BSS bottle. Like you need to make that a little bit bigger. So that's definitely a really good point, Dr. Winslow.
So I went to the OR. I went to the OR with Mike Ober last week, just to see, his setup and watch some of his surgeries. And he does a PI from the anterior, not from the posterior. And I was just wondering, what the more popular thing is. I always did PIs posteriorly, but I couldn't think of much of a reason to not do it anteriorly. Is there some theory behind that?
I do both. I think for the aphakic, especially, sometimes it seems to work pretty well both ways, I think.
What did he do? Was he coming through the pars plana?
No, he was doing a Yamani IOL, so he had a clear corneal incision.
Yeah,
so he just came in.
Yeah, if he already had but most of these cases we're not going to have the vast majority of these cases, you're not going to have any anterior access unless you make another opening in the eye. I wouldn't do that.
Right. So if you did have an opening, there wouldn't be a downside of approaching from anterior, correct?
I don't think it'd make any difference.
For the aphakic ones, you could actually go from pars plana. If you hold the retractor in your temporal, you just go anterior and flip it backwards.
Yeah.
Sometimes I do the anterior, I feel a little more comfortable where I am exactly in terms of.
just to make sure in cases where you have capsule left, doesn't apply here, but that you get both the capsule and the iris. So.
The other consideration is sometimes it might be better to make those earlier than later because they'll sometimes bleed. And then,
Okay.
if you've done it early in the case, you know, it'll usually stop spontaneously. If you do it the last step and then they bleed, then you have to screw around and get the bleeding stopped and da-da-da-da-da. Whereas if you've done it earlier and there's a little bleeding, then it usually self-resolves during the surgery.
And the other thing I learned it the hard way too is you use a slow cut rate when you're doing these. Use a very slow cut rate.
Yeah.
Otherwise, it won't come to you until you put enough aspiration, and then you eat the whole chunk of iris.
Yeah.
If let's say I were to have bleeding in this case, do you usually just wait it out? Do you touch it with the diathermy? Do you
I've
have a
never
different strategy?
I've never diathermized it, but it's bothersome. If it happens at the end of the case, it's just sort of.
I never hesitated to diathermize them.
Okay.
I never have. There'd be no reason not to that I can think of. Yeah.
Well, it might be more, you know, it might be more inflammatory. I mean, that thing, does the diathermy, does that create more likelihood of fibrin closing your membrane?
Okay.
The other thing I would mention is I always strongly consider using Myocol before making the PI if I have that chance, because when the pupil's dilated and you're trying to make a generous PI, it's going to be bigger when the pupil contracts. And I've had a handful of cases with the silicone oil migrating forward. So just make sure you make it not too small and not too big.
You know, the problem with Myocol is, do you want to do your, you know, your fluid air exchange with after putting in the Myocol?
Yeah. Well, in some cases, I mean, I've done it before and it works. In some cases, I do not. So.
And then, so then we went to go through from PFC, kind of make sure we are able to drain as much BSS and then the PFC to get the retina under air. So actually one thing I want to talk about really quick on this step was something that Dr. Chapman and I had talked about in clinic earlier this week, was that the PFC kind of creates this bubble, and then around the top of the bubble, there's this halo of fluid, this space, and really attacking that space around the edge of the bubble to dry as much as you can to make sure that none of the fluid kind of leaks posteriorly back once you take your PFC bubble down. Which I don't know if it's demonstrated well in this video, but it was something that I actually noticed that we did, and Dr. Lin had advised on this case as well, is really trying to dry above the bubble. And here it worked well from the level of the break as well. And then kind of, work our way posteriorly.
I think that's a good point. Basically, that's the old sandwich technique.
Okay.
One thing I like to do when there's PFO in the eye, the fluid phase is much smaller in volume. And so what you can do is just open up the ports with a vitrector so that you have some fluid flow. Make sure you flatten your infusion, but that kind of circulates fluid and gets rid of a lot of that pigment that's in that fluid phase and maybe the cellular elements. I'm not sure that it's studied, but that's something I do.
Okay.
Sorry, that's my daughter in the background.
Actually, Dr. Lin talks about doing the Abrams wash, where you do a couple of drops of VSS onto the macula once it's flat under air, and the PFC is out, just to make sure you get any residual PFC, and if you capture any of the other cellular debris that might just be sitting on the retina, to try and give it one more chance to drain.
Dr. Abrams, does anybody else, because when I hear other people talk about that technique, they just refer It's your technique, so I don't know if anybody else was doing
We
it.
didn't invent it.
No, he didn't invent it. We even do it here in Dallas.
Okay. Okay.
Yeah, I mean, we published and talked about it
Oh,
on
you
our
did. Okay.
on
Okay.
our paper on subretinal perfluorocarbon liquid. We talked about it, and so I think that added to it catching on, but we didn't invent it. I don't know who invented it. Brett, one thing I was going to say is if you've got a first-year resident in there with you or a medical student, you want to be sure that they see the eye before you start it.
Okay.
And then they look at it at this point in the case, and they'll all want to be vitreoretinal surgeons. Because, I mean, can you believe the difference in this eye from when you started?
It's a
Unbelievable.
pretty remarkable case.
Unbelievable. I mean, it's beautiful now.
It is.
Mhm.
And that's, you know, that you'll turn them all into wanting to be vitreoretinal surgeons.
Perfect.
Too much competition, Gary.
That's all right. That's
Yeah,
all right.
easy.
More the merrier.
And then then basically we went to silicone oil. She stayed flat under air. She looked really good. We unfortunately don't have any post-op photos, but last time, as far as the notes go, you know, she's still attached under silicone oil and she looked pretty good. So,
In terms of tamponade, you know, this kind of case, will you always use silicone oil? Can you put in C3? You know, by silicone study, you know, it sounded like you can do C3F8 for many of these. I mean, I get too nervous in this type of case.
Actually, interestingly, in the silicone study, the C3F8 eyes did very slightly better than the silicone oil eyes in primary in eyes with first operation for PVR.
Because the surface tension is better with the C3F8, is that why?
I think probably you tamponade you know, as long as you got a big bubble and they position prone, you get really good tamponade of the inferior retina with it. Of course, if you got an incomplete fill and you're not tamponading that inferior retina, that's a problem. So you got to make sure you get a complete fill. So one thing you want to do is always repeat your fluid air exchange. You know, ideally wait 15 minutes, but most of us are not patient enough to wait 15 minutes, but we'd wait 10 minutes at least by the clock and then repeat the fluid air exchange. And you're always amazed at how much more fluid comes out after waiting a few minutes.
Gary, where's that fluid come from?
You know, I think two things. One is kind of like a glass of water, and you've got the fluid that's attached, that's hanging on to the edge of the glass, and it slowly just drips.
Okay. I like that
down.
concept. Yeah, I hadn't thought of that. I like that concept. What else?
And the second is I think you could progressively compress any residual vitreous at the vitreous base.
I've heard that theory also, yeah.
I don't know. Those are the only two things I can think of.
What do you think about aqueous production?
I don't know. What do you think?
Well, I would think it wouldn't be enough, but
Okay, if you waited another 10 minutes, would you get the same amount of fluid? I don't think so.
it seems like you could just sit there all day and you could keep sucking and keep getting fluid as long as you, I mean, I used to wait 15 minutes and then I just couldn't stand it any longer and shortened it up. But it always seemed to me you could sit there all day and get a little more fluid if you waited long enough.
Well, you have to have good music. That's the only thing I can figure if you're going to wait. Sit around and wait 15 minutes. You know, have to have good music.
Yeah.
Well,
Do you change are you less strict with your positioning instructions with silicone oil?
No.
Yes.
So Dr. Abrams, for that case, can you get away with C3F8 gas rather than, you can, okay. That was okay.
And do
In
you
fact, you know, it's a first operation for PVR, so there's a lot of people who would frankly prefer to use C3F8 because you didn't make a big retinectomy. You've got that, a couple of breaks, but they're insignificant because they're not under traction. So there's a lot of people who frankly prefer C3FA.
I'm one of them. I would prefer C3FA. Do you close all of your sclerotomies with silicone oil?
I do.
Yeah, we do too. The other little thing is if you have made any entry into the AC, did this was this the one that had the lens removal?
Yes.
Yeah. So you have, at least in our experience, you have to be sure you close those anterior chamber incisions very carefully, or you will get migration of oil into the AC. Because if that burps and you get a lower pressure in the AC, then the oil will often come forward.
Yeah, I think we sutured up everything usually for these.
Yeah, we sutured at least our clear corneal incision. We did not suture the para. I don't know if Dr. Winslow, if you have like paracenteses in the anterior chamber, would you suture them?
I would try to close it up because
Okay.
we had I remember a case with a fellow that we had done minimal stuff, but there was some incision in the cornea and there was oil in the anterior chamber the next morning. And that's the only thing I could think of.
Was it oil within fluid or was it just the whole AC filled with oil?
Say it again, Cece.
Was it oil bubbles within fluid, within aqueous, or was it just the whole AC is filled with oil?
No, it was oil within AC fluid.
Okay.
Yeah.
The other situation that we should mention is when, at the end of your air fluid exchange, your iris is completely plastered onto the cornea, and then you put in silicone oil. What do you do in those situations?
Usually, you can take any instrument and go up and pull the iris a little posterior, and the gas will fill in front of the iris and hold it back.
I just want to.
You're asking. I don't know if that's your question exactly.
In terms of, do you do something about it, or do you just do your normal fluid exchange, or do your normal gas exchange or fill up with oil?
I try to pull the iris back and have air go in between the iris and cornea.
Okay. Because I had for gas, I don't think I really had that situation as much, but for oil, if it's plastered completely on the, by the time you're done with your silicone oil fill, if your iris is completely plastered on your cornea, that you don't have an AC, if I don't reform it a little bit, it tends to sometimes just get stuck there.
I agree. I always like to get that off the cornea.
Yeah. One thing we have done once was a situation, I think Dr. Chapman and I, where that situation happened post-op, and we just injected a small, basically air bubble between the iris and the cornea, and just have them look around. Yeah. And a little air bubble just dissected it back off.
Yeah.
So I was just asked to comment on a lawsuit or an impending lawsuit about a gentleman who had a giant retinal tear plus additional tears. They did a vitrectomy, sutured one of the sclerotomies, and then post-op day 1, he was fine. Post-op day 4, he comes in with a new pain, and he has subconj gas. And the doctor put a needle in the conj to evacuate the gas, and he commented that the gas bubble was 60 to 80%. So how do we decide whether there is, with proper positioning, of course, even like almost upside down positioning, how do we comment, or how do we decide whether to take the patient back to the OR for a full, to replete the gas?
I want you to do a post-op fluid air exchange.
You mean in the office?
Yeah.
So you would do that if it, like, for what percentage?
I wouldn't take the patient back to the operating room to get a bigger gas bubble.
And so for what percentage would you do a procedure would you risk doing a procedure like this? This guy couldn't even tolerate, he was taking pain medications, and he found the whole vitrectomy experience very painful, which is very atypical. And so his pain tolerance was probably pretty low. So what would be your indication? Like if you had 80%, or is there a certain percentage that would make you want to do an air exchange?
Well, if you've got occasionally, occasionally you'll get, if you've done a lot of laser and the retina starts elevating, and you got a lot of laser on the retina, you'd want to, I think you'd want to get, occasionally you get necrotic holes in that area, and you'd like to get the retina flat. I actually had that situation in a patient with a schisis detachment. So what we did is I used a higher concentration of gas, used one needle, he laid on his back, and I just went in and out, pull out about half cc, push it in and out, and I equalized the gas in the eye, which I assumed would be about 10%. And this, I think at about 25% or so in the syringe. And I equalized the two, assuming I'd get some expansion of the gas bubble, right?
Mm-hmm.
Because I'm going to have someplace between 10 and 25%, so I should get a little expansion in the eye. And CC and I spent, remember when we were trying to calculate what we should use, and we were never successful. So you just kind of guess. So anyway, then I had him back the next day, and he had 100% gas fill, but his pressure was about 30. So we tapped him, actually, took a little gas off, and he came back the next day, and he had 100% gas fill, and his pressure was about 30. So we tapped him again, and the next day he was perfectly fine. But he had 100% gas fill. So that's one way you can do it. The other way you can do it is you'd use a 2-needle tech. If he's aphakic, you can just put him prone and use a single syringe in the limbus, and you just you just inject, and then you kind of push up, and the fluid will escape around the needle in the prone position. The third way you can do it is if you want to have a known concentration of gas, you use a 2-needle technique, and you put the patient on his or her side, and then it's harder for the patient to do. And if you're going to do that one, you better use a retrobulbar block, because they don't tolerate that very well. And you'd put a needle in the nasal limbus, and then with the gas, the known gas concentration, and then you'd put a second needle through the temporal limbus, which is inferior, and then you just inject and then aspirate with your other needle, and you can then get a known gas concentration in the eye. So there's a lot of ways you can do it. All of them are very doable, and if you've got a compliant patient, you can do it. Probably the least painful would be to put them on their back and just use a single needle and just try to estimate how much expansile gas you're going to need to get it to expand a little bit and fill your eye up. And that really works well.
Mm-hmm.
That's not painful, because you're just going in to the pars plana while they're laying on their back, and they do that. They should do just fine on that.
I guess back to
what was the pressure post-op day 1?
For the case,
Yeah.
it was 17.
Okay. All right, different story.
Yeah, so asymptomatic. Yeah, so something happened between day 1 and day 3 that the gas leaked. I suspect that maybe because the guy was in pain, he was taking pain meds, and maybe he gagged or vomited or something to make that Valsalva.
It's a pissy lawsuit. That's all I can say.
Yeah, that's what I told the lawyer.
Deepa, I guess the question was whether, in what situation would you take a patient back purely for gas underfill?
Yes, exactly.
I guess would you ever take it? I mean, most of the time, I guess it's more if it's detaching because of the gas underfill rather than the gas underfill itself.
Is that, I guess that would be an acceptable, I guess that could be a good strategy to follow. I mean, typically I mean, there are some surgeons who want to advertise like the least amount of face down or the least amount of gas, for these patients that, need to get back to their life or need to get back to whatever traveling. For me, I tend to I'm always erring on the side of a full gas, C3F8 or longer gas. That's just me, or more face down positioning, like for 7 days instead of 3 days. But I'm wondering if I saw the patient post-op and they didn't have a full gas, I would probably just say, be very strict about your face down positioning, because most of the gas where you need it will touch those areas, right? If they're face down.
Right. At 80% gas fill and they're face down, you'll tamponade, everything.
Yeah.
Be
so I guess what is the percentage that, let's say it was a macular hole, what is the percentage that we should be uncomfortable with at day 1 after surgery?
I'd say if it's 60%, I'd be very worried.
Okay.
80%, as long as they'll position prone, you should be just fine.
Yeah, that I would feel the same way.
Though I like 100% better.
But yeah, exactly what CC said. Like, if the patient is detaching, then they have to go back to the OR. But that's
what are you going to do if you have 65 patients in your clinic and this person's quite anxious? Are you going to spend 45 minutes to an hour and a half doing an exchange? Just playing devil's advocate here.
You just give them some Valium.
Just give him Valium and send him home.
No, have the fellow do it.
I would say give him some Valium and take some yourself.
I'll take some too.
Well, everyone, it's 7 o'clock, and we had some good discussions today. I was going to look at what's the next surgical conference. I think next month we may be doing a journal club rather than a surgical conference.
Yeah, I think it's actually the resident. Isn't next week the resident journal club?
Yeah, so there's next week where the resident's doing a surgical journal club, but they're only doing 2 or 3. It's not the same as our journal club. I think they're only doing 3 papers. And I think usually we do a journal club every quarter just to catch up on the main articles in the past couple months and anything. And it's a rapid fire. We do maybe like 8 to 10 papers, but that's now it would be since COVID, major papers. And I think that's what we're gonna, on October 15th, that's what we have. And then in November, I think our surgical conference would be macular surgery. So I'll continue to send out to everyone the links to the surgical conferences and the journal clubs if anyone's interested.
Okay, sounds good.
Right.
CC, have you been able to record your CME credits?
Yeah, you have to do it Friday morning. Sorry.
Because I've been trying to record mine for the last 2 weeks and the site's been down.
Oh, yeah, I had the same issue too. Yeah.
Ingrid said she was going to try to get it where, usually you're supposed to do it within a week, but the site's been down, I think, for about 2 weeks.
Yeah. So Dr. Winslow and Abdul, these actually give CME credits that we use when we have 1 CME credit for these conferences.
Yeah, if you sign up, anybody from outside, they can sign up for Wayne State CME credits and they'd be able to get credits for these if they want to get CME credit.
Yeah, and they're all category 1 CMEs. I put the CME code in the chat box for this session.
Thank you, and thank you so much for including us. I really appreciate it.
Well, thanks for coming. Thanks for
coming. We appreciate it.
Thanks.
Appreciate your comments.
All right, thanks everyone. Good night, everyone.
All right, good night.
Right.
Good night. Thank you all.